Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks, what is compassion fatigue? And another question here asks about the trauma-seeking mental health clinician type that we see sometimes in clinical practice, otherwise known as the narcissistic wounded hero type. Now, I was going to answer these questions separately in separate videos, but compassion fatigue actually kind of links in to the wounded hero mental health clinician. So what I'm going to do is answer the compassion fatigue question, and that kind of explains the foundation necessary to understand the trauma-seeking mental health clinician. So starting with compassion fatigue. Well, I'll explain what compassion fatigue is, but first it's important to understand there are a few other names that are related, like vicarious trauma, and sometimes we hear the term secondary traumatic stress. Now, these are more or less synonyms, but you could think of secondary traumatic stress as a part of compassion fatigue, and I'll explain how that works in a moment. So, when we look at the two parts of compassion fatigue, the first part would be burnout. Now, burnout's a fairly common term. We hear it all the time. It's a psychological syndrome that involves a prolonged response to chronic interpersonal stressors, and usually these occur at work. So we see physical, mental, and emotional exhaustion resulting from the long-term engagement in emotionally demanding conditions. And it's characterized by frustration, feelings of hopelessness, anger, and the symptoms of burnout usually come about fairly gradually. We don't expect burnout to kind of suddenly occur, but instead we see it occur slowly over time. Now, burnout can happen to anybody. Compassion fatigue is usually thought of as reserved for people in the helping professions, but burnout can happen to somebody who makes a living in sales, somebody who's a mechanic, a lawyer, a computer programmer. Really anybody in any occupation can burn out. And of course, I mentioned there are consequences to that. Now, burnout, as I indicated, is just a part of compassion fatigue. The other part is secondary traumatic stress. So the two together equal compassion fatigue. So secondary traumatic stress is a harmful reaction to work-related trauma that can occur when somebody's exposed to clients' accounts of traumatic experiences. So if a client comes in to a session with a counselor and the client talks about their own traumatic experiences, the next client comes in, they do the same thing. This occurs hour after hour, day after day. That can have a cumulative effect and lead to secondary traumatic stress. And the symptoms here would include intrusive thoughts, memories, negative mood, avoidance, and arousal. So all the same symptoms we see with post-traumatic stress disorder. So compassion fatigue is not a mental disorder, but it may be something that qualifies somebody for a diagnosis of post-traumatic stress disorder. So as I mentioned, burnout and secondary traumatic stress come together. They form compassion fatigue when somebody works with highly distressed clients or clients who have a trauma history, which of course would be highly distressed. And anybody in this category is really at a risk for developing compassion fatigue. So if somebody works with clients who have had traumatic experiences, they're at risk for this. Now, other than the emotional and physical exhaustion that characterizes compassion fatigue, we also see a reduction in the ability to feel empathy and compassion for other people. On top of that, we could see nightmares, sleep disturbance, grief, anxiety, depression, difficulty with relationships. When we talk about what affects competency, we're really talking about this lack of empathy. Eventually, a lack of empathy develops. And we think, of course, this is due to the chronic use of empathy in helping people in distress. By using the ability to understand how somebody else feels, that cognitive ability, and affective empathy would be where somebody shares the experience of a client. I would call this empathy and sympathy, but sometimes these are called cognitive empathy and affective empathy. But either way, overuse of this skill, overuse of this ability, is what causes compassion fatigue eventually. Now, I mentioned that compassion fatigue is not a mental disorder, but it could have a relationship to post-traumatic stress disorder. And that's because one of the qualifying traumas in the definition of post-traumatic stress disorder would be repeated or extreme exposure to aversive details of a traumatic event. So again, if a counselor is hearing a client talk about trauma over and over, that would qualify as meeting that criterion. So how prevalent is compassion fatigue? So is this something we see a lot or rarely? Well, there aren't a lot of studies about compassion fatigue. Our best research indicates that over 50% of individuals in the helping professions, including psychotherapists, report moderate to high levels of emotional exhaustion, which is a part of burnout, and of course burnout is a part of compassion fatigue. We also see that about 50% contemplate quitting their jobs, specifically because of emotional exhaustion, and we see that somewhere around 15% may meet the full criteria for PTSD. Now again, we don't know how accurate that information is, but even if it's somewhat close to 15%, that would still be a lot of clinicians who are being affected by PTSD because of compassion fatigue. Now, some of the studies indicate there's another construct called compassion satisfaction, and this is when somebody gains pleasure from helping others. So, not pleasure necessarily from hearing traumatic stories, but pleasure from being helpful, pleasure from helping people to get past symptoms, to have a remediation with symptoms. Now, some of these studies have also suggested that compassion satisfaction can help balance out compassion fatigue. But I'm a little skeptical about this. I think that somebody can like the work that they do, they can gain pleasure from it, and yet still have compassion fatigue. I don't see compassion satisfaction as being highly protective against compassion fatigue, but I suppose it makes sense that it could be somewhat protective. So the role of compassion satisfaction notwithstanding, what's the bottom line with compassion fatigue? Well, somebody can no longer feel compassion for others. A clinician can't feel compassion, and they are generally impaired, because feeling compassion would be an important part of being a mental health counselor. So we see there are techniques that can be used to help avoid compassion fatigue and to deal with it if it's already set in, like self-care, having fewer clients on a caseload, and having a more balanced caseload. So not having all clients who have a traumatic history. Now, this isn't what we see, of course. A lot of caseloads are imbalanced, and I'll talk about this more in a moment. So is compassion fatigue something that happens out of the blue to mental health clinicians? Like, is it something that's unexpected? I think generally it is. I think that most mental health clinicians are kind of surprised by the power of empathizing too much or sympathizing too much. Now, most clinicians who experience compassion fatigue use one of the techniques I talked about before, self-care, changing the caseload, maybe changing positions, and some even leave the field of mental health counseling, although we would hope that would be kind of a last resort. But most take some sort of action to try to deal with and adjust to compassion fatigue. Now, unfortunately, some do not, and this kind of gets to the second part of this video, the second question, which is the trauma-seeking mental health clinician. I talked about before also this is called the narcissistic wounded hero type counselor. And fortunately, this is just a very small percentage of counselors, but I have seen this phenomenon a few times. So not all mental health clinicians are really cut out for trauma work, right? That's what we have to start with here in terms of understanding this construct. There are many other types of work available in counseling. Someone could treat other mental disorders. They could deliver career counseling services, marriage and family counseling. Now, to be fair, trauma is common, but there is a way to reduce the amount of trauma somebody sees in their work as a counselor, again, through selecting an agency or selecting a caseload that has less trauma experience in it. Now, some mental health clinicians know that they're not cut out for this work, but they want to work with trauma victims anyway. And this is where we get into the trauma-seeking mental health clinician. Sometimes this is because the mental health clinician was a victim of trauma, and this makes sense that if somebody's a victim of trauma, they want to work with people who are also victims of trauma because they can relate and perhaps they think they could share their story and it might be helpful for the client. In my years of supervising and consulting, though, I have seen this pattern where there is this trauma-seeking mental health clinician and there's certain characteristics to this profile that I think are a little disturbing. And I think it is important that as members of the mental health community, we're aware that these type of clinicians are out there, and we have to be aware to take the appropriate steps when in a supervisory role, or even really if one of those clinicians were our colleague. There's still steps we might have to take to kind of deal with some of the behaviors I see in this particular pattern. So, as I mentioned, some mental health clinicians keep coming back to trauma work, even though they're really not appropriate for it. Now, other mental health clinicians seek out trauma work, and they are appropriate for it. So, again, I'm talking about a small percentage of people that have an incompatible personality or an incompatible skill set, depending how you want to think about it. So here are some of the characteristics of the trauma-seeking mental health clinician. And again, I'm talking about negative characteristics, not the trauma-seeking mental health clinicians that do a good job. So the first thing I mentioned is they do tend to have a trauma history. This isn't a good or bad thing. It's just something I've noticed. And we know that when a clinician has a trauma history, they are at a greater risk of developing compassion fatigue. This is actually a fairly important risk factor for compassion fatigue. Now, the next item I've noticed is what I call an unusual ideology. So these are just things that the mental health clinician says that kind of indicate a state of mind that may not be healthy. For example, they might say something like, "You're not good enough as a mental health clinician unless you're falling apart." So kind of indicating that the clinician needs to be suffering along with the client. Another kind of quote I've heard is, "How can you not be crying after hearing that story?" So there's a lot of emotionality with the trauma-seeking mental health clinician. They oftentimes express emotions, and that would include crying, in the sessions. So this is kind of a part of their counseling technique. And of course we know from good practice with mental health counseling that crying in the session is usually not a good idea. Specifically, of course, I'm talking about crying on the part of the mental health clinician. The next item is they look at what I would call normal mental health clinicians, meaning mental health clinicians that seem to perform pretty well in their jobs and they're fairly typical for the profession. They look at these normal mental health clinicians and they describe them as cold and distant. So this really speaks to the narcissistic wounded hero mentality of this trauma-seeking type mental health counselor or clinician. So they're putting themselves kind of a different spot where they're willing to suffer for the client and other mental health clinicians aren't willing to suffer. So they're becoming cold and distant to that trauma-seeking mental health clinician. So the idea here is nobody can really understand this mental health clinician. They're kind of on their own. They have kind of a sense of entitlement and a sense of being special or unique. So again, we kind of see narcissistic characteristics with this type of mental health clinician. Now, another thing we see here is they confuse empathy and sympathy, or cognitive empathy and affective empathy. And they overuse the affective empathy or the sympathy. So they're feeling the same way that the client feels rather than understanding how the client feels. So this is kind of an interesting aspect of this type of clinician because they're really saying they're good at empathy, but essentially they're good at sympathy, and that's not a counseling skill. So they're overusing the wrong type of empathy in counseling. Now, overuse of sympathy leads to compassion fatigue, and compassion fatigue leads to losing the ability to feel compassion for others. So this is really kind of the paradox of this particular type of counseling style. If you overuse sympathy, you develop compassion fatigue, and therefore you can't have compassion. Now, you can still have sympathy, but compassion is something different than sympathy. You could think of compassion as cognitive empathy and maybe a little bit of affective empathy and some other attributes, but sympathy would not generally be a significant part of compassion. So again, sympathy can still be experienced, but compassion is gone when compassion fatigue has set in. So again, this clinician becomes generally impaired. They become unable to deliver quality service. So the sense of competency for the narcissistic wounded hero clinician is based on their own pain. So it's kind of like that phrase, no pain, no gain, except the pain is on the part of the mental health clinician and the gain or lack of gain would be on the part of the client. So really this is about blurring a boundary. And we know compassion fatigue also has a relationship with over-involvement with the client, and we see that here as well. The clients, the survivors of the trauma, end up validating the mental health clinician. So the mental health clinician needs to continually hear that their feelings, the mental health clinician's feelings, are valid. And of course we know this is not the client's responsibility to meet the needs of the counselor. But that's exactly what happens with this type of trauma-seeking clinician. They get some sort of need met from hearing these different stories and from telling their stories. And that really brings me to the next part here. We see that these type of clinicians are more likely to share their trauma story with the client. And of course, research tells us this is generally not a good idea. Self-disclosure in general kind of has mixed reviews. Some clinicians believe it's good and some believe it's bad. I would say really there's a lack of evidence supporting that it's good. So some self-disclosure is fine, but telling your trauma story as a counselor to the client is usually a bad idea. And if you were going to express kind of the attributes of your own trauma story, you'd want to do it slowly over many sessions and make sure that the client was okay with that. What you don't want to happen is this vicarious trauma occurring to the client. And that's exactly what happens with the trauma-seeking mental health clinician. Their behavior leads to re-traumatizing the client. So again, very unhealthy. The last characteristic of the trauma-seeking mental health clinician that I'll cover here is, in my experience, they seem to be more likely to be less qualified. So they struggled in their educational process, they struggled in their early career, they were never really an exemplary counselor, which kind of makes sense considering that their skills aren't really developed. And we see that sometimes they're just plain not qualified at all. Like sometimes I've seen in these situations that the person isn't actually a trained counselor or other type of psychotherapist, but rather a life coach. And of course I talked about life coaches before and how life coaches can be extremely problematic in terms of taking their own trauma story and believing that everyone else's trauma story must be the same, and kind of overgeneralizing that experience and giving out bad advice. So again, that would be the last characteristic here that I'll talk about for the narcissistic wounded hero counselor. Now, you may look at all this and say, well, this could just be attributed to different styles. Every counselor has a different style. But this is beyond stylistic differences. This is bad practice. The excessive self-disclosure, having counselor needs met by the client, the blurry boundaries, the compassion fatigue, all these characteristics are actually quite problematic. I've seen the damage that these types of counselors can cause, and I feel for them. I understand that many of them are victims of trauma as well, but protecting clients is a higher priority for the mental health treatment community. We want to do the right thing for counselors that need to be helped in terms of clinical ability and maybe shouldn't be in the field, but we absolutely have to protect the clients. One particular horror story I remember pretty well was with a mental health clinician in training, that's kind of the best way to describe it, who ended up taking a client who had a trauma history and taking that client into an office and spending 2 hours explaining their own trauma history. This is the mental health clinician kind of unloading their own trauma history onto the client. It was nothing short of a disaster. And I took appropriate action to make sure that client was cared for and to deal with the kind of employment issues of the mental health counselor in training, I'll just put it that way. But this is what we really need to do in the mental health treatment community. We need to be aware of these situations and try to get in front of them and minimize damage. Now, that situation could have been a lot worse. Fortunately, I was in a position to act in an appropriate way and, again, care for the client. But these are the kind of things that can slip through if one is not paying attention. So we do have to be aware that, unfortunately, even though the vast majority of counselors are very good, there are a small percentage that can cause a lot of damage. And this trauma-seeking mental health clinician is one type of counselor that can cause damage. Now, I know whenever I talk about trauma and counseling and narcissism and these different topics, there are going to be a variety of opinions. If you agree with me or disagree with me, have other opinions, please put those in the comments section. They always generate an interesting dialogue. As always, I hope you found this description of the trauma-seeking clinician and compassion fatigue to be interesting. Thanks for watching.